Sarah Dugan. I'm a mental health pharmacist and faculty at Neomed. Our presentation topic for today is drug interactions. Bobby, you're in my squares. Can you see my slides? Yep, perfect. Thank you. So recognizing this is a relatively large topic, I wanted to provide a general overview of drug interactions as opposed to trying to identify and march through individual drug interactions that you may encounter. So we have two really broad objectives. I want to identify the two main categories of drug interactions and to describe how those interactions may impact drug therapy. So generally what might happen with that. The reason for that is I mentioned, I think there's too many to go through individually. I did identify a few examples there to try to highlight the mechanism of how those things may interact. And then you'll see at the very end some of the potential actions that we could take to assist with the interactions. So to start with our drug interactions, an interaction is when a drug modifies the action of another drug in the body. And the two main categories that we encounter are pharmacokinetic and pharmacodynamic. And we're going to spend a little time exploring both. But a couple considerations I'd like you to keep in mind throughout the presentation. Not all of the interactions are clinically significant. So just because there may be an interplay between the two drugs in the body, it doesn't mean that it's going to change things for the patient. And in some cases, it may not. Also, interactions in some cases could be really beneficial, so it might be a benefit for the patient. In other cases, it might be detrimental and something that we need to adjust so that it doesn't cause harm. So it can go in either direction. So our two categories, pharmacokinetic and pharmacodynamic. So we're going to start with our little man over here on the left-hand side. So our person takes a medication. The pharmacokinetics are what the body does to that drug. The pharmacodynamics are going to be what the drug does to that body. And we're going to look at them in quite a bit more detail. So as an individual takes a medication, so if you have a headache and you take a Tylenol, the medication is administered, you need to get it from that tablet or capsule form into your body. So the absorption is step one. How it gets absorbed into the bloodstream and gets all over your body, but most importantly up to your head to help with your headache. So absorption, getting it into the blood, distribution, getting it up to the brain, but then it is a foreign entity. So the body needs to do something with it. So it oftentimes will metabolize it. So it changes the drug itself so that it can then excrete it or eliminate that agent. The drugs, when they're in the tissue, so all of that is our pharmacokinetic component. When the drug is actually in the tissue, so as the Tylenol makes it up to your brain, we can get two types of effects. So what the Tylenol actually does, hopefully it kills the pain of your headache, but it may also cause some side effects. So we could see both of those, and those are our pharmacodynamic effects. So we're going to hit on interactions that we can see in both of these places. I'm going to start with pharmacokinetics. There's a little bit more related to this, so I wanted to make sure we dedicated some time here. So those four different compartments of pharmacokinetics. Derek is our pharmacy student who's on here today. So we are going to do this in about 7 minutes. They get multiple courses on this. So this is definitely a broad overview. If you have questions, please feel free to reach out to me afterward. So of our four different areas of pharmacokinetics, you can have interactions at all of these. From the absorption side, sometimes if you take two medicines together, we don't absorb things quite as well. I put a bottle of antacids there. If you're taking antacids with some antibiotic medications, it'll bind to the antibiotic and your body will never even absorb the antibiotic to fight your infection. So you can have interactions at that point. We can also have interactions in a positive way of food. So my family that's at the table here, In some cases, we need to have eaten a certain number of calories in order to optimally absorb a medication. So Geodon, ziprasidone, and lurasidone or Latuda are two examples where if you take it on an empty stomach, you don't absorb as much. So that would be an interaction, almost a food drug interaction, to try to make sure we get optimal absorption. Distribution, we need the drug to be able to get to where we need it to be. Many of the medications on a psychiatry or neurologic standpoint need to get into the brain, so they need to be really lipophilic. So they have to like the fat tissue to be able to get in there. Sometimes that can be really challenging to keep it where we want that to be. So that is occasionally a consideration, and there are things that can move it from going into the brain and potentially going to other areas of the body. Metabolism we're going to spend the most time on, but our excretion or elimination often is either in the urine or in the fecal matter, and there may be potential interactions there as well. If we have something that causes the drug to be eliminated a little bit faster or even more slowly, could potentially cause some changes for the patient. But metabolism is our focus for today. So metabolism, the main role of it is to change the drug so it's easier to be eliminated. And that could be adding something to it, or it could be potentially making it like water more. I said it has to like fat so it can get up into the brain. Maybe if it likes water more, we can get it out into the urine a little bit easier. We're focused on the liver for today. That's the main site for a lot of our drug metabolism. And we have protein enzymes, so almost little factories that help break down the drug or change the drug so that we can get those eliminated. Our focus for today is going to be on our cytochrome P450 enzymes. So these are the most common enzymes that do metabolize the drugs that we may take, that the patients, the kids, and the families that you interact with all take. So there's, from a nomenclature standpoint, there's three different things that we're going to talk about. So substrates, inducers, and inhibitors related to metabolism. So substrates are the drugs that are metabolized by the enzyme. Inducers are drugs that make the enzyme activity increase. They make it even more, a greater amount of enzyme activity. And inhibitors are drugs that reduce the amount of enzyme activity that we have. So I have a visual for you. So drug A are our blue triangles. So those would be a substrate for one of the hepatic enzymes or our little factories here. So drug A is in the body, it goes to the liver, the enzyme works on it, and it's sent for elimination. So those enzymes process a certain amount of drug over time to help your body get rid of it. So as you see, some of them have started to fade. Yeah, those are ready for elimination and they're on their way out of the body. If we add an inducer drug, and we'll look at some examples of inducer drugs, but those are going to be our yellow diamonds in the bottom example. So we have drug A on board, but now we've added the inducer. The inducer will have the body either make the enzyme more efficient, but in most cases, it actually makes more enzymes. So we have more factories to process the medication. So in this case, you see that the drug A, almost all of them are faded. They're all about ready for elimination because the body can process a lot more of the drug much more quickly. So those concentrations are going to lower and we're going to get less of an effect from that medication at the same dose. So we may have to make some adjustments. So that's on the induction side. For the inhibitor side, so we have the same example at the top with our substrate, but if we have an inhibitor drug, which is our orange circles down here, they can either make the enzyme factory less efficient, or it can bind to the enzyme factory and take it offline completely. And what that does is it means that that enzyme can't process drug A anymore. So as you can see here with our blue triangles, those haven't been changed. They haven't been faded. So they're really not ready for elimination, which means we have much higher concentrations in the body than what we had before. And that increases the risk that patients could have adverse effects, even though we didn't change the dose of that medication. So with this in mind, here are some examples of common inducer medications. So things like some of our seizure medicines, carbamazepine is your Tegretol, phenytoin could be your Dilantin, oxcarbazepine is your Trileptal. So if they're exposed to these, then they may make more of those factories. Now I have my little tortoise down there, because it takes time for the body to make more enzymes. So this won't happen right away. This will happen over, usually it takes about a month for the body to make more enzyme. So you'll slowly start to see those concentrations go down. So we have more metabolism, less drug. So we may have to increase the dose of some of those other medications. Cigarette smoke is in there. That's tobacco smoke. So if individuals are exposed or they themselves smoke, tobacco cigarettes, there are aromatic hydrocarbons in there that actually can induce some of your liver enzymes, and it makes you process some of the drugs a little bit faster. That's important for agents such as clozapine and olanzapine. On the flip side, our inhibitors are my hair in this example. They're super quick. They can bind to those factories, those enzymes, and either stop or reduce the amount of drug that they can process. Less processing means higher concentrations, increased risk for adverse effects. And here's a number of common inhibitors. I want to draw your attention. We've got a bunch of the antidepressants that are on there. Our SSRI medications like fluoxetine, paroxetine, those are common inhibitors that we need to keep in mind. But sometimes there are antibiotics or antifungal medications as well. So if a new medicine is added, it's really important we look at the whole profile because it might cause some changes. So that's the pharmacokinetic side. Now we're going to shift gears a little bit and take a look at the pharmacodynamic side. So really what the drug does to the body itself. So first of all, we can have synergistic effects, so really additive effects. So drugs that are working together and we get kind of an enhancement or an amplified effect. An example of this might be sedative medications. So medications that can cause drowsiness or sedation. So some of our medicines like some of our anti-seizure medicines like Depakote, that can cause drowsiness sometimes. So can some of our other medicines, like medicines that we use for ADHD, things like clonidine sometimes can cause sedation. So if we have a whole bunch of medicines that can cause sedation a little bit, that patient might be really sedated or overly sedated. So that might be a bad thing if it's too much sedation and the child is falling asleep. But on the flip side, if we're using a bunch of medicines that are all sedating, maybe that helps with agitation or anxiety or other symptoms that the patient has, and those get calmed down a little bit. So same effect, same interaction, but two different outcomes. So it's really going to be patient specific. Another example is with serotonergic agents. So there are a lot of medicines that work on serotonin, our neurotransmitter. And as we have more of them that increase the serotonin, there is a risk for a potentially serious condition of serotonin syndrome. So I use this example, fluoxetine. Maybe it's being used for anxiety or depression, and maybe the patient has bedwetting, so they're also on imipramine. So as we have two antidepressants that both increase the amount of serotonin, there is a potential risk for the development of serotonin syndrome, so that would be bad. But on the other side, if it increases serotonin, we might have benefit in both the bedwetting as well as maybe a boost in helping with the depression and anxiety symptoms. And in that case, that might be a benefit. So as you can see for a number of these examples, increasing things, we really got to look at the patient's individual situation because it could go in either direction. We're going to look at the flip side in just a second, but to set that up, I wanted to talk about receptors. So a lot of our medicines work on different receptors, so they can work on different ends of the spectrum. If you think of it almost like a dimmer switch, where the agonist is the light is completely on. An antagonist is what a lot of our antipsychotic medications do. And it's not actually the opposite of having the light on. It's almost like having the light in the middle. So there's some light, Maybe it's not as bright as it could be, but it's brighter than it would be if the light was completely off. The opposite end, that inverse agonist, is almost like something's making the room darker, where it's completely off and it's the opposite of giving light. There's something that's almost like taking that light away, and that would be the completely opposite effect. And that's one of the things we want to keep in mind, is if we have agents that are working kind of in opposite of each other. And this is just another way to look at it. Our neurotransmitter or agonist, they can turn things on so we get some positive effect. The antagonist, which can be a bunch of our medicines, and I'm going to use that in an example in just a second, isn't going to do nearly as much. So it may look like it's the opposite effect, but we're definitely not getting what we were. And then the inverse agonist would give us that complete opposite reaction. So sometimes we do have medications that are working in those opposite ways. So drugs that really are opposing each other. So one example that I like to use that's a medical example is patients who have urinary incontinence. So individuals that may be incontinent of urine, they're taking a medicine to help them not urinate all the time. And maybe they're also on a water pill, which is one of the first line agents that we use for high blood pressure. Well, that would make you go to the bathroom all the time. So that would be another example of working in opposite directions. We're making someone go to the bathroom all the time, even though that might be a big problem for them. So we're trying to avoid some of those situations. On the a little bit more mental health side, things that you may see are patients who are on stimulants and also need sedating medications. So we have something where they're on a stimulant and maybe we're looking for that to kind of help with maybe their ADHD, but we also have agents that are really sedating that may be offsetting that a little bit. Stimulants and antipsychotics. So stimulants are going to increase our neurotransmitters like dopamine and norepinephrine, and our antipsychotics are going to block some of those receptors for dopamine. So maybe it's not going to be able to do quite as much as it could if that wasn't on board. Another example comes from the case that we saw last week. So antipsychotics, they block those dopamine receptors. Some individuals may be on dopamine agonists, things that are supposed to be turning those receptors on for things like restless leg syndrome. So if we have both of those on board, they're kind of fighting for the same number of receptors. So we got to see if we're getting efficacy or side effects from those combinations. Another combination I just wanted to put in there for a pediatric population, you may have some individuals that are on beta blockers, things like propranolol or Inderal. They may be using it for anxiety or for tremors or for restlessness, but maybe if they have asthma, they're also on an inhaler like an albuterol. Well, those can compete for those same receptors as well. So it's important that we look at the big picture to kind of see, okay, are we maybe only using this sometimes? Do we still have efficacy for it? And what should we do for those patients? Which means it is not a straightforward path. We have a number of different doors that we could go through. Evaluating the symptoms. Are the symptoms improving for the individual? Are things working the way that they're supposed to? Are we getting side effects? So if we're getting improvement in what we want, we're minimizing the side effects, then maybe we don't need to change the therapy. If that's not the case and there are problems, maybe we're not getting the effect that we want, or we do have a lot of side effects, then we may have to look at making some adjustments. In some cases, that may mean changing the dose, increasing or decreasing the dose, or seeing if there's a different agent that we could do. So just to wrap up, our two big categories are pharmacokinetic interactions, so those changing of concentrations, and our pharmacodynamic interaction, so amplifying or potentially diminishing the actions of a drug. But regardless of which category they're in, it's really an individualized assessment to figure out what's going on with each of the medicines and if we need to take steps moving forward. That's my presentation, and I will stop share and turn it back over.